Greetings, my name is Lindsay Ma, and I'm a rising intern in internal medicine. Today we'll be discussing acute kidney injury, or AKI, and how to diagnose and initially manage it. The target audience for this talk is clerkship level medical students, so let's see what we can learn today. To start, what is acute kidney injury? Well, it's when the kidneys become injured in a short span of time, and usually this damage is reversible. To start, let's break down AKI into three buckets, as this will help form the framework for how we diagnose and treat AKI. The first bucket would be pre-renal. The second bucket is intrarenal. And the third bucket is post-renal. You might become concerned about AKI due to certain lab abnormalities, or perhaps a history or physical might make you suspicious for AKI. Let's start with the pathway where an abnormal lab value makes you concerned. What are some of the lab values that might make you worried? If the creatinine rises greater than 1.5 times the patient's baseline, or if the creatinine rises more than 0.3 within 48 hours, or if the creatinine rises more than 50% within 48 hours, or urine output becomes less than a half a cc per kg per hour. These are all reasons that should make you suspicious for AKI. So before you got your history for your patient, it's possible that elevations in creatinine or reduced urine output increase your suspicion for AKI. If this is ever the case, then you would want to go over and do an evaluation, get a history, and get the rest of an exam and labs. On that history, you want to ask about PO intake. Are they getting enough fluids, or could they potentially be dehydrated? The other is urine output. This is an indicator not just for whether their kidneys are working well, but if there is even fluids to urinate off. If a patient is third spacing a lot, even if they're taking in fluid, there isn't enough intravascular volume for the kidneys to see and to excrete. You can also ask for the items that relate to your differential, which we'll talk about in the blue boxes in a little bit. You can ask about risk factors for items on that differential, and that will help you hopefully distinguish between certain AKIs or if this is an AKI at all. On exam, you'll want to check for vitals, namely heart rate and blood pressure, as this can indicate a little bit about whether they might be dehydrated or what their intravascular volume is like. On that note, you'll want to check fluid status, check for edema, JVD, etc. You'll want to check their mental status exam as well, and urine output. There are three important labs to collect when you're suspicious for AKI. One of them may be obvious to you since we talked about creatinine, and that would be a BMP. On there, we're specifically looking at creatinine, BUN, electrolytes, calcium, and glucose. Why are we looking at these specific things? Well, creatinine and BUN can give you a little bit of a hint as to whether the etiology is pre-renal or intrarenal. Electrolytes tell you a bit about what underlying diagnoses they might have, and if there are complications developing from this AKI, which warrant more urgent management. Calcium can also tell you about etiology, such as if this patient has developed one of the malignancies that commonly cause hyperkalemia and injury to the kidneys, as well as glucose, since patients with diabetes and complications of diabetes, such as DKA, can develop AKI. The two other lab items we want to get include assessment of the urine, and lastly, we want to get a CBC. This again will help tell us if there is low blood counts or elevated leukocytes that may point towards intravascular depletion and infection respectively. While we wait for those labs to come back, is there anything we can do? There is one thing we can provide the patients. If they look intravascularly depleted on exam, we can empirically try a 500 cc bolus of fluids. This is because prerenal AKIs are treated with fluid replacement, and prerenal AKI make up about 20% of AKI cases. However, the extra fluid could complicate other conditions the patient might have, such as heart failure. And so you'll want to be cautious as you decide to give fluids or not. If the patient's status improves with the addition of fluids, say with improved urine output, then even before your labs come back, you may be leaning towards a prerenal cause of AKI. All right, so now that labs are back, what kind of BUN to creatinine ratio would we expect for patients with prerenal AKI? Typically, we expect a BUN to creatinine ratio greater than 20. However, this is not a hard and fast rule. If you look on their urinalysis, you might see bland results. And this would be because there's no bacteria or blockage or toxin to cause bleeding or white blood cells or pathogens. If you happen to calculate a FeNA, or a fraction of excreted sodium, it'll probably be less than 1%. This is because the body is using sodium to move fluids. And so if the body thinks that there is intravascular depletion, the body will hold on to sodium in order to keep fluid in the blood vessels. And therefore, the amount of excreted sodium in the urine is relatively low. Now let's say the lab values look like a prerenal picture. What are the underlying causes that you'd be able to treat? We talked about one, which would be decreased intravascular volume. You could also have shock. It could also be due to hyperglycemia or hypercalcemia, like in the case of multiple myeloma or in the case of DKA. Because hyperglycemia causes dehydration, it can cause AKI. And same thing for the case of hypercalcemia. Therefore, prerenal AKI is sometimes simplified to hemodynamic AKI. What is the treatment for prerenal AKI? Similarly to the empiric fluids we gave, the treatment would be replace fluids. You'll then want to recheck on your progress in intervals at around 6 to 12 hours. As the patient improves, you can stretch out the intervals between creatinine checks. The next category we can look at is intrarenal AKI. What are some of the lab findings we may notice for intrarenal AKI? BUN to creatinine should be normal or low, so less than 20. On urinalysis, you might see muddy brown casts. You could also see sterile pyuria, or in other words, the presence of white blood cells in the urine without the presence of bacteria or pathogens. And FeNA is probably greater than 2%. And then on history, you might have heard them say some toxin exposure is present, which gets us to the causes of intrarenal AKI. Very commonly, there are nephrotoxic medications that are the culprits. These are very commonly NSAIDs, ACE inhibitors and ARBs, SGLT2 inhibitors, can include antibiotics like vancomycin, and chemotherapy medicines like cisplatin. These are just a few of the common examples and are not all inclusive. Intrarenal AKI could be due to a progression of a prerenal AKI, which is why I have this blue box here extending and including all of the items in the prerenal category. So what is the treatment for intrarenal AKI? Ultimately, it's to remove the insulting agent. The way that I remember that intrarenal is all about the insulting agent is by looking at the first two letters, IN in intrarenal, as well as IN in insulting agent. Our last category is postrenal AKI. When you gave some empiric fluids, they did not improve. And ATN, a common cause of intrarenal AKI, is unlikely based off of their history. Then you might be thinking of a postrenal picture. So that would trigger you to get a renal ultrasound most commonly to evaluate for hydronephrosis, which is simply a sign that fluid is backing up into the kidneys. What kind of specific item should be on our differential? We talked about stones like nephrolithiasis, as well as urolithiasis. Pyelonephritis can also be a cause of postrenal AKI. And then malignancy, as well as strictures, can all cause fluid to back up and ultimately lead to hydronephrosis. What is the treatment for postrenal AKI? We'll want to relieve the obstruction. This could be via medication in the case of small stones or just fluids. Other times, you might need antibiotics, like in the case of pyelonephritis, or the patient might need a procedure to address a malignancy or stricture that's blocking antegrade flow from their kidneys through their bladder and out their body. In the case of intrarenal and postrenal AKI, we don't expect the improvements with treatment to be as rapid as with prerenal AKI. So we will recheck creatinine in 24 hours for intrarenal and recheck creatinine in 7 days or so, like 1 week after treating an obstructive or postrenal AKI. The last thing I wanted to mention is there are times when creatinine is elevated, but the patient does not have an AKI. And the common reasons for this include a hemolyzed sample, pregnancy, and high muscle mass. All three of these things can cause elevated creatinine without causing an AKI. And lastly, if the workup for AKI is unremarkable, they might end up having to get a biopsy, but we won't go into those details today. All right, so to summarize, acute kidney injury or AKI is a usually transient, short-term change in kidney function. You might become suspicious of this based off of an elevated creatinine on labs, which would prompt your evaluation. Or on their history and exam, you might find that the patient has low urine output recently and signs of dehydration or blood loss or kidney stones that make you worried about AKI. Either way, you'll want to get 3 labs, the first being a urinalysis as well as a BMP. Lastly, you'll want to get a CBC. While you're waiting for these labs, you can consider empirically repleting fluids. Once your labs come back, you will want to assess things like the BUN to creatinine ratio because this can help distinguish between prerenal and not prerenal AKI. You should also look at the urinalysis and see is it bland or are there things like muddy brown casts. Lastly, if you collected urine lights, you can calculate a FeNA with a low FeNA suggesting prerenal AKI, whereas a higher FeNA can suggest intrarenal AKI. As you look at these labs and incorporate items from their history, you'll have hopefully diagnosed prerenal or intrarenal AKI. If you've diagnosed them with prerenal AKI, the treatment will be to replace fluids and address the underlying cause such that their intravascular volume can come up. On the other hand, if the patient has known exposure to nephrotoxic medications and has the laboratory findings we discussed above, then you might be suspicious for an intrarenal AKI. The treatment for all intrarenal AKIs is to remove the insulting agent. If all of the labs look pretty normal, but instead the patient has a history and exam suspicious for an obstruction, you might be looking at a postrenal AKI. You'll want to get a renal ultrasound in order to assess for hydronephrosis and relieve the obstruction if there is one. If the entire workup that we discussed is unremarkable and the patient still has AKI, then a kidney biopsy may be warranted and nephrology should certainly be consulted. Your time is precious, so thanks again for joining me for this talk. Until next time.